Welcome. This is Professor Wheeler, and we're going to continue with the second part of the mood disorder lectures. This second half will focus on bipolar disorders. Again, the reading is still our free textbook here, Chapter 7 and Chapter 8. And then Lena Chen, Part 1, and Sharon Cole is the one on bipolar disorder. All right, our objectives define mania and bipolar disorder. We'll discuss etiology or cause of bipolar, discuss medications used for it, and the nursing process and treatment of the bipolar client. So definitions: bipolar mood disorders that include one or more manic episodes and usually one or more depressive episodes. And just to be a little more clear, to what we're talking about here is bipolar 1, where a patient in the course of their history of having the illness, if a patient has gone all the way to the extreme of mania, they're going to be considered bipolar 1 if regardless of what their current mood episode is. And so a manic episode is an unstable, elevated mood. Usually there's psychosis involved. When you think of the continuum of mood with the extremes of elevated mood versus the extremes of depressed mood, at each extreme you can possibly have psychosis. The kind of psychosis in mania, it's usually kind of grandiose delusions. They can be paranoid as well, but they're they're more likely along the lines of kind of grandiose. All right, and they cannot function. One of the differences between mania and hypomania, a patient in a manic episode cannot function at all. A person that's hypomanic can still be very productive and focused. They're going to be very irritating to their coworkers and might have a lot of conflicts, but they can still function. The person in a true manic episode cannot. All right, so here we're talking in more detail about bipolar 1. So bipolar 1 generally has some psychosis in a manic episode, what we call rapid cycling. Rapid cycling, it's one of the more misunderstood concepts. People think it means their mood is jumping around during the day, up and down, but that's not rapid cycling. That's actually what we would call a mixed mood episode. Rapid cycling actually just means they've had 3 or more distinct mood episodes in a year. Let's see. Bipolar 2, it just means that they haven't gone all the way to mania. They've only gone to hypomania. And so they have a lot of mood instability. They spend more time depressed, and they spend more time in a mixed mood state where they go to hypomania and then to severe depression. And sometimes the poor impulse control that you have with an elevated mood in hypomania, it overlaps with the hopelessness that people have in their depressed episodes, and that happens in a mixed mood episode. And that's a very high risk for suicide. Having the impulsiveness and the hopelessness at the same time is a very high risk for suicide. All right, so I touched on this a moment ago, but mania patients can experience psychotic symptoms. That's one thing that differentiates mania versus hypomania. They don't have psychotic symptoms in hypomania. And like I said, they can function, they'll still be grandiose, and they'll have a decreased need for sleep with flight of ideas and racing thoughts, but they can still function. All right, so the etiology or the cause of bipolar disorder, we generally believe it's genetic. You'll see that about if you have somebody with bipolar disorder in your family, the chances that you will have bipolar disorder is much higher than the regular population. I think it's about 10 or 15%. If you have somebody that has your identical genes, like in the case of somebody that's an identical twin, you'll have bipolar disorder about 50% of the time. So like we said in the first lecture, it's not 100% of the time, so it's not 100% genes, but it is much higher than the rest of the population. All right, so just heading along in treatment planning here for the different kind of areas of our lives. So there's an alteration in nutrition, usually because the person is hyperactive and they're not eating enough. What happens is they get undernourished, and so what we have to do is give them what's called finger foods, which is foods that they can carry around when they're walking around, when they're pacing. We can't give them something like a big bowl of soup or something that would be dangerous. They could scald themselves. And so we also want to give them free, small, frequent, high-calorie meals and have a quiet environment for them to eat because they're going to be very distractible. So risk for suicide when they have mixed symptoms. So the highest risk is when they've been at a high for a long time and they come down and they have an overlap, like I said, with the mixed episode where they have those kind of thoughts of hopelessness and dying going into depression, but they still have some of that poor impulse control from their mood being elevated. They also, once they're not delusional anymore, when they're coming down from the mania or hypomania, they can see the consequences of their actions. So they may have spent a lot of money. They may have done sexual things that are outside their comfort level or their normal behavior. They may have done a lot of infidelity and being having trouble with their spouse accepting that. Um, so yeah, they can see the consequences. Also, a lot of times it's a very you have to think when somebody has a grandiose delusion. I'll tell you a common one with young men that they'll have a grandiose delusion that they're going to be a big rap star and they're about to be a big rap star, a music like a famous musician. And when they're coming down from it, they realize, no, I'm not a famous rap star. I'm actually a very sick person in a hospital. So you can imagine that's a devastating drop, and that's very hard to take. Um, yeah, so you can kind of understand why that's a very painful landing when you are that far away from reality, then you come back to reality. Okay, so there's also a risk. They have poor impulse control, so they're a risk for other directed violence. They sometimes can be very provocative to other patients. They can also act out sexually and be taken advantage of by other patients that might prey on them. So you have to set limits. They're going to be, they might be sexually provocative in their dress and in their behavior. They need a lot of redirection around that. You might need to, if it's a vulnerable patient, and you might need to put them on a one-to-one, so they have a staff person watching them. So sleep pattern, generally when a patient has had an elevated mood, they're very sleep deprived and they're exhausted. When we give them medication, generally an atypical antipsychotic or even a typical antipsychotic, it once you kind of get them to sleep, they'll sleep a lot, and you might even worry that you gave them too much medication, but really it's not the medication you gave them so much as they're sleep deprived and they're actually exhausted. Their body's exhausted from being revved up, and so they're sleep deprived and they're exhausted. We want to try to give them a quiet environment. Uh, Generally, we don't want them to have to deal with a roommate or a roommate to have to deal with them, and we want to let them sleep as much as they can. We don't wake them up for groups. Um, the most healing thing for them that they need is sleep. All right, and then diversional activity, they're generally not going to be able to sit still for a group where you have to like sit there and wait your turn and let other people talk and not interrupt. And so you don't bring them to those kind of groups, but they can do physical activity, the ones that are exercise. One of the things that we do on my unit, because there's a little patio where patients can play basketball, is we'll take them out there and let them shoot some baskets. Anything that kind of gets their energy out a little bit, they, those are good. But anything that requires them to like sit and wait their turn, listen to other patients, we don't want to put them in that kind of position because they're going to fail and they're going to make other patients upset. All right, so sexual dysfunction. What's really a big problem is sexual acting out. Um, Sometimes a patient will do things. I'm thinking in terms of a teenage girl that goes and has sex with a bunch of people, and it's from a conservative background, and sometimes you'll have to explain to parents that it's your daughter, that's part of the illness. It's not a reflection on her character. It's the same with boys. Um, so we want to help the patient reduce their shame if they've done that kind of thing, help the family, and if the spouse, if it's an adult, understand that this is part of the illness. This isn't the person has no morals. This is the illness, and so they need to help the person get over the shame and not be putting more shame on them. All right, and this is what I was just talking about. So it's very common to do things that are outside of your values when you're in a manic episode. And when the person comes out of the mania, they're going to feel bad about that. And so that's when they could be at a risk for suicide. Um, we need to make sure that the parents understand and the spouse understands that that was just part of the illness. All right, so cognitively, when the patient is not going to have good decision making. They're going to be very impulsive. So we want to try to avoid power struggles with the patients when we're setting limits. Also, just like with depression, they need to postpone serious decisions. They can make very impulsive decisions. I had a patient one time who was well, I won't say what his profession was, but for confidentiality, but he was a employee that he would, when he got manic, he would email his boss and tell him off and quit. And the boss valued him very much. And so when the boss would get that kind of email, he would just forward it to his wife and tell him, it looks like he needs to go back to the hospital for a while. And so usually that's not the kind of that was a very supportive boss. It would be great if all bosses were like that, but it's not the case. Um, but anyway, they need to postpone serious decisions in the hospital. That's why when somebody's in a psychiatric hospital, they can't sign legal paperwork for, you know, divorces or things like that. They're not considered competent at that moment, especially if they're on a legal hold. All right, and then one of the things that we have on our side when we're trying to set limits with a patient that's manic or hypomanic is they're very distractible. So you don't want to get in a power struggle because they're going to have way more energy than you. But you can just remember to try to distract them and talk about something different. Usually, if you know the kind of thing they're preoccupied with, you can distract them easily with that if you change the subject to something along those lines. All right, and then if they can tolerate reality orientation, we do that. That's not always true when a patient has grandiose delusions. Sometimes they'll get very agitated. Sometimes their delusions, you know, and a common one is, I own this hospital and you've got to let me out or I'm going to fire you, those kind of things. Um, if the patient, as long as they're not doing anything, we can let them have those delusions. You don't need to confront them. If they're trying to take your keys or things like that, then that's different. But we try to get them whatever we can do that makes it okay within their belief system to take meds. We try to do that because that's what they really need, and we have to protect them from their own behavior. All right, and then medication noncompliance. So this is part of where we need to help them with their medication compliance. There's something that's called the kindling effect, if you're familiar with that with seizures. And what that means is the more time somebody has a manic episode, the more times they're likely to have a manic episode. So it's like your body gets sensitized to it, just like people that have seizures. You don't want people to go on having seizures because it not only is it's very dangerous, but it also makes it more likely they're going to have seizures in the future. So it's the same way with manic episodes. So there's other things with medication noncompliance I'll talk about later on with things like lithium, where you have to make sure the patient understands some of the effects of the medication that are expected and go away, like the nausea when they first start taking it. Also, you need to make sure to never give it to a patient on an empty stomach because the patient will get very nauseous and think they're allergic to the medication, and then they won't take it. They'll think they're allergic when they're actually, that's kind of expected if they're not used to it. And they never should get lithium on an empty stomach, especially if it's new, but really never. Right, medications for bipolar disorder. So lithium is really the most effective one that we have. It takes a week to 2 weeks to reach therapeutic levels. It's great to have them in the hospital because we can do their levels. Generally, it's like twice a week if we're not being real aggressive when we're implementing the lithium. If and the patient meets with the doctor every day when they're in the hospital. So if the patient's having a lot of side effects, the doctor can go a little slower in titrating it up. But if they're not, they'll be more aggressive. And like I said, they need to take lithium with food. They need to have enough fluids, but not too much. Um, if they have too much fluids, it keeps the lithium level down. They need to understand the side effects. One of the great things about lithium, it's really good for preventing mania, and it's one of those three biological factors that has consistently shown in research to reduce suicidal feelings. There can be some weight gain involved, so that's a negative if your patient tends to be a little overweight. But generally, it's our most effective medication for bipolar disorder for most people. All right, so they need to have a normal salt intake. And I remember one time a student asked me, well, why don't we just not tell them anything and assume they're going to do their normal salt intake? Well, lithium is a salt, and so it's complicated, but you have to educate the patient, or they're going to go by what their crazy uncles that always has an opinion on something, what they say. Um, so what that means is if they take in extra salt, which most people don't, it'll give them those kind of high blood pressure, those kind of problems. If they don't take in enough salt, what happens is the body will use the lithium in place of the salt that it's missing, and then you won't get the therapeutic effect from the lithium. So lithium is medication that has a very narrow therapeutic range, and so what that means is the level that you need to have in a person to be therapeutic is uncomfortably close to the level that causes toxicity. So it's very important to educate patients about toxicity. And the biggest problem with toxicity is getting dehydrated for some reason. It can be, from having the flu with diarrhea, vomiting, or sweating. Those are also side effects of, when people are starting to get a little bit toxic. That's like the body's defense mechanism trying to get some of it out. Um, but dehydration for any reason, if they have the flu, if they're if they're going to run a marathon, they shouldn't take their lithium that day. That's an example of the kind of teaching that patients on lithium need to know. They shouldn't take diuretics, or at least the doctors should be aware. They shouldn't take aggressive diuretics. And then it's metabolized by the kidneys, so they need to have their kidneys, in addition to their thyroid, checked periodically. So some of the expected side effects is little minor tremia, polyuria, which means they're going to urinate a little more, and having increased thirst. So that's like the body's mechanisms to flush something out. It's like a defense mechanism. So that's, a little bit is what's expected. So nausea, if they're feeling nauseous, we want to, have them eat something that's settling on their stomach. I have drink milk on the slide here, which is okay if they're not lactose intolerant. There's so many people that have problems with lactose. I should probably change that on the slide. But if food's not effective, then we give them, medication for nausea. So early signs of lithium toxicity, nausea and vomiting. And really the key is the vomiting, because nausea can kind of, with lithium, be a chronic issue, at least in a minor way. But really the vomiting, and then diarrhea, and being really thirsty, and again, polyuria, urinating a little more frequently. That's an expected side effect, but it's something to keep an eye on if it's getting worse. And lethargy, they're kind of like in a stupor, and their speech is getting slurred. Those are signs, definite signs of toxicity. Also weakness, and then the fine hand tremor. It's a little worse than the expected fine hand tremor. So the treatment is, of course, you're not going to give them the next dose of lithium. You're going to contact the doctor. You'll expect a stat blood test, to check a lithium level, and then generally the treatment is IV fluids if we're determining the cause is dehydration, which is usually the cause, and so you'll expect to give IV fluids. All right, severe toxicity can be deadly, and that's a coarse hand tremor, and that's where the hand is, you can visually see it kind of jumping around, and they can't even sign their name. It'll be, they have trouble holding a pen. They're very confused. Their gait is unsteady from ataxia. Their vision is blurred. They can have seizures, blood pressure dropping. They can go into a coma, and then usually a big sign is they'll wet their pants. They'll pee their pants because they have this large output of urine, and the urine is basically, it's clear, it's dilute, and basically it's the body trying to wash something out that the body feels like it's been poisoned. So medications used to treat bipolar. So besides lithium, Depakote, it's probably the treatment of choice for mixed mania and depression and rapid cycling. Depakote, again, you have to check the blood levels monthly. And when you're starting a patient on it, just like with lithium, you have to check them more frequently because everybody metabolizes these medications a little bit differently. And so, the doctor, before they can determine a dose that keeps the patient at the level that's therapeutic, they really need to be checking the blood levels and adjusting the dose to try to keep the blood levels where they're in the therapeutic range, but not risk for toxicity. Depakote is metabolized by the liver, so it can cause an increase in these liver enzymes. Mainly the ones you'll see is the ALT and ALP, and you'll need to teach along those lines. You'll need to teach the patient about liver toxicity, those kind of symptoms, because that can be a sign that their Depakote is causing their liver to have problems. Common side effects: tremors, GI upset, and weight gain. Those are kind of similar to lithium, But with lithium, it seems like the nausea is much worse. All right, and then we also have lamotrigine. It's the same, from the same drug drug section as Depakote, where it used to be a anti-seizure medication. Well, it still is probably an anti-seizure medication, but it's been shown to help with mania. And one of the things with lamotrigine, the brand name's Lamictal, it it also has FDA approval as a mood stabilizer. So something like Depakote, even though it's the same drug class, it doesn't help people keep out of depression, but lamotrigine can. All right, and then lamotrigine, it's the kind of negative thing with it is it seems to cause more Steven Johnson problems than the other ones from that category. And so any rash that the patient has should be evaluated by a doctor. And they shouldn't ignore any rash that they have. All right, and then other ones that are from the anti-seizure category that have been effective for mania, Tegretol, and I'm not sure if I have it on here, but Neurontin would be one of those also. And it's not used as much. It's usually only used if there's a reason why the patient can't take the other ones. All right, so this is our kind of wrapping up this topic here. The first line of treatment, it's usually going to be either Depakote or lithium. They can also use atypical antipsychotics to quell the mania, especially at the start. But there's some doctors that also use atypical antipsychotics if the patient seems like they only have manic episodes or hypomanic episodes, but never really have true depressive episodes. There is thinking out there with some doctors where they'll just try an atypical antipsychotic, like maybe Seroquel seems to be the one they use the most, along with Risperdal and Abilify. So anyway, what's really dangerous with bipolar disorder, if it's treated just with antidepressants, that's usually when somebody looks, when they come in and they're depressed and the doctor doesn't know that they have manic episodes or hypomania, and that can be very dangerous because it can trigger a manic episode in that person. All right, so I'm going to end here, and be sure to look at the study guide for the reading and for the study questions. And thank you for listening and watching.